Good evening, everyone, for joining us once again. Uh, so we have been hearing about pain, and now we have covered communication. And today we'll be hearing about the role of palliative care, or how important or when to integrate palliative care in non-cancer illness, or the spectrum of illnesses that can come under the palliative care services. Today we have Dr. Sunita Daniel as our faculty. So, Dr. Sunita has rich experience in palliative care field, and she has been working with NHS in UK. Currently, she is in Cochin, working as a special medical officer under National Health Mission, and she has a lot of publications in. I think in if you just Google it, you can read a lot of interesting articles by Dr. Sunita. Thank you, Dr. Sunita, for being with us for today's session, and over to you.
Thank you, Sridevi, and thank you, Palliative, once again for the opportunity. So I'll start by sharing my screen. My slides are visible, right?
Yes, it is visible.
Okay. Just a small correction. I'm not working with NHM right now. I've resigned.
Sorry, I just saw the designation.
So I'm an advisor with Karkinos Healthcare. It's a private oncology platform which deals with from cancer screening to palliative care. So I'm sort of working as advisory role there. Anyway, so we'll start with the session. So the idea, I mean, the session, what we're aiming to find is to understand why it's important to get palliative care involved in non-malignant conditions. So, traditionally, we always thought that palliative care was for cancer conditions. And initially, it was like that. It's always started like that. But then now we've realized that even non-cancer patients need palliative care input. So what I'm trying to cover, very briefly in the session is to see which all conditions, we can have a role and how do we make a difference. And, and that too, only few points about each condition, because within 1 hour, we can't cover the whole spectrum of non-palliative care, non-cancer conditions. So you must all be familiar with this traditional WHO definition of palliative care. It's an approach that improves the quality of life when there is a life-threatening illness. And, our aim is to prevent and relieve suffering. And the important thing is early identification and assessment of pain, other problems, physical and psychosocial and spiritual conditions. So there we used to think as a life-threatening illness, life-limiting illness. That was the importance in 2002. But in 2018, we sort of made a change in the definition. So now we believe that palliative care should be offered to not just a life-limiting or life-threatening illness, but any illness that can cause a serious health-related suffering to an individual. And there is a lot more in a number of conditions in there. So this came in 2018. The International Association for Hospice and Palliative Care brought up this consensus definition, and it's been accepted by experts worldwide. So what are those serious conditions? What are the SHS conditions? They have also listed about 20 conditions in the Lancet article where this SHS was defined. And we can see cancer and leukemia, malignant neoplasms are there. But in addition, we've got lots of other conditions, including atherosclerosis, chronic ischemic heart disease, CVAs, dementia, liver diseases, hemorrhagic fevers, HIV. So all these are now being included. And, in addition to the cancer and tuberculosis, all those communicable diseases are also coming there. So, so that is why the scope of palliative care is expanding now. Now, this is a map which shows how this spectrum of SHS of serious health-related suffering is going to change from 2016 to 2060. So it's a predicted increase, what they have shown in this map. And they have divided based on the World Bank income region. So if you can see from the map, what you can understand is that, so dark green is where the it shows low income and low and middle income countries, so where India and other countries come in. And you can see that the SHS is going to increase by 155% and 87% respectively in the low income and low and middle income countries. So we are going to have a very large burden of serious health suffering conditions? And are we prepared to face that? Are we prepared to manage such patients? And this is again the burden and the map which shows the burden. So malignant neoplasms is still topping the list, but you have cerebrovascular diseases and lung disease and dementia also. The number is going to increase, expected to increase when you reach 2060. And this is the distribution of the major cause of death in India. And you can see that the graph in red is the communicable disease. So previously, 1990s, the communicable disease was the major cause of death in India. But now the number of people dying because of communicable disease is coming down. And you can see that NCDs, the cause of death, the number is actually coming up. And the top one, the injuries or the RTA still remain the same. So the NCDs are becoming a major burden in our country. So what we believe is that this is data from ICMR in 2017 regarding the state level disease burden. So which shows that about 48 to 75% of the current disease burden is NCD. And the highest number is coming from Kerala, Goa, and Tamil Nadu. And the lowest numbers is actually coming from Bihar, Jharkhand, Uttar Pradesh, and Rajasthan. So this is a 2017 data. I'll move on to first quiz. So this is just I want to make it an interactive session. So this is a simple MCQ, and explanation will be given in the subsequent slides. So what is the most common symptom cluster of advanced cancer, as well as AIDS, heart disease, COPD, and renal disease? Is it A, option A, pain, breathlessness, or fatigue? Option B, pain, vomiting, constipation. Option C, breathlessness, delirium, constipation. Or option D, depression, anxiety, anorexia. Just, whatever you think is the answer, please put in the chat box. We'll just give maybe 10, 20 seconds for that.
I think majority are the responses are for A, except
okay.
one C.
Right, so that's the correct answer. So pain, breathlessness, and fatigue are thought to be as a common symptom cluster. So why I mentioned this question is because this was a comparison study as is published in Solano et al. As early as 2006. So and what they found is that they published this paper, and they tried to analyze what are the symptom clusters towards end of life in some non-cancer conditions as well as cancer. And the three common symptoms that were seen was pain, breathlessness, and fatigue. And here are the rest of the symptoms. So you can see that cancer, there are lots of symptoms. Dyspnea, pain, fatigue, depression, anxiety, anorexia is there. But similarly, similar to cancer, we've got similar symptom burden in other non-cancer conditions like HIV, heart failure, COPD, CKD. In fact, the breathlessness, the prevalence of breathlessness in COPD, which is 90 to 95%, is more than the breathlessness in a lung cancer patient or any cancer patients. It's only 10 to 70. Similarly, heart failure, 60 to 88%. So these non-cancer patients do have a lot of symptom burden. But because they're not technically, cancer patients, unfortunately, they don't get the help that they should be getting. So that's where the early integration of palliative care into non-cancer comes in. Now, so we'll take the individual conditions as I mentioned before. So we'll first start with COPD. And this study was published in 2000 in Thorax, and it compared the state COPD and lung cancer patients. And what they found was that the patients with COPD had poor quality of life, as well as more breathlessness compared to the patients with lung cancer. But none of the COPD patients received specialist palliative care services. But lung cancer patients, obviously being a cancer diagnosis, will get that. And the breathlessness, the prevalence was 94% compared to 78%. So this was as early as 2000. So at that time, there weren't much of palliative care service for non-cancer, even in the Western world. Another study was done. This is a prospective cohort study of seriously ill patients who are hospitalized with COPD and lung cancer. Now they were asked, like towards end of life, how, do you want to be, do you want to have supportive care, and or do you want to go in the ventilation route? And both the proportion of patients, similar groups of patients in both the, both lung cancer and COPD, they preferred a comfort care and didn't want ventilation. So about more than 60%, and did not want ventilation, about 80%. So the patients in COPD group and the lung cancer group actually towards end of life didn't want any ventilation. But what happens is that subsequently, because at that time there wasn't advanced care planning and discussions were not there, towards the end, what happened was most COPD patients received ventilation, that is 70% versus 20%. So even though the patients are also, doesn't want to have a, aggressive end of life management, but they tend to get that, or they used to get that, because they were not being seen by the palliative care earlier on. So what can we do in such patients? So how do you manage dyspnea and advanced COPD? Now, this is a chart. It's the table of management of steps of management of dyspnea and advanced COPD. And when you learn breathlessness, I'm sure this will be covered, because there's a lot of there's a lot of role that palliative care as a specialty can offer these patients. And there is a new term called chronic breathlessness syndrome now, just like chronic pain syndrome. We have coined chronic breathlessness syndrome mainly to make sure such patients get visibility, and such patients are referred for these services. So as we all know, when a patient has got COPD, the management starts with the usual cocktails of short-acting bronchodilators, long-acting anticholinergics, inhaled corticosteroids, all those medications are given, and patients gradually go on and initially get better. Then gradually, as the disease progresses, they get worse. The breathlessness get worse. So what we do is these patients are kept under regular follow-up by the pulmonologist. Now they come to a point when they're on maximal medical treatment for their COPD, including all the inhalers, and they can think of and steroids, and they still become breathless. So once they're on maximum medical treatment and then they're still breathless, that's when you define the chronic breathlessness syndrome. And this breathlessness is affecting their normal day-to-day activities and affecting their quality of life. So that's when there's a lot of role of palliative care and supportive services. So we go into a step of referring them for the non-pharmacological management of breathlessness, which will be covered in a breathlessness session. So things like respiratory exercises, training for pursed lip breathing, walking aids, and chest wall vibrations, and neuromuscular stimulation. And then still the breathlessness is not getting better, then you start with the opioid treatments, and that you can use both short and long acting opioids. So morphine can be used for them. Again, you'll study details of this in your breathlessness session. So that's how you manage COPD patients step by step. So we come to our patient now, Mr. Kumar. He's 70-year-old and has advanced chronic obstructive pulmonary disease. He attends the clinic to see you due to his worsening breathlessness. Despite maximal medical therapy, he has had 3 admissions to hospital in the last 12 months with exacerbations of his COPD. He was assessed for home oxygen therapy while in hospital, but he did not meet the criteria. Your clinical assessment excludes any reversible causes of infection. So every time a patient comes with breathlessness, obviously you look for reversible causes like infection. So if there's reversible, we know that chronic COPD patients can get a recurrent bronchitis and infective exacerbations of COPD. So you assess for that, and he doesn't have any reversible causes like infection. So what do you do next? Which of the following would be the most appropriate next step in managing the patient? Is it A, prescribe a benzodiazepine as a low dose to be taken when he feels especially breathless? Or B, prescribe a short course steroids and antibiotics and ask him to return if he does not feel better? C, refer him for cognitive behavioral therapy as anxiety is likely to be a contributory factor? Or D, discuss the use of handheld fan, explore whether the patient would be willing to be referred for advice regarding breathing exercises and involvement of the palliative care team? Or E, prescribe morphine 20 milligram orally as required. So I'll give you again 10-20 seconds for that.
A few Ds and 1, 2.
Few Ds.
Yeah.
Okay, good. So that was the answer I was looking for. So you can see that benzodiazepine anxiety measure can be given, but not the first line. So these people do have panic attacks. So you assess them carefully, and then you can add benzodiazepine, but not immediately right now. Then steroids and antibiotics probably not indicated because it doesn't have any infection. CBT again has a role, but not as first line. We start the others first. So you can refer him to handheld fan, has got evidence-based as a non-pharmacological management. Again, this will be taken in bed person session. So you can start that. You can ask whether he's be willing to refer for the breathing exercises and involuntary palliative ketamine. Morphine can be started, but that's not the dose you start for breathlessness. So you go at a very lower dose, and again try non-pharmacological first, and then go for morphine. Okay, now we'll come to heart failure. So heart failure, it's quite a common condition. In UK, the incidence is about 1 per 1,000 population. And from all the literature that I could find, the evidence in India, prevalence actually there's a variation heart failure. So it's 1.3 to 23 million is the total prevalence of heart failure. What most people don't know, and even patients don't know, is that the survival rate from heart failure is actually worse than breast or prostate cancer. That means breast or prostate cancer that is diagnosed at the early stage. What we normally know is that if you can find them in a very early stage, actually you can probably cure breast and prostate cancer, but you can't of heart failure patients. So survival rate is actually worse than breast and prostate cancer. And half of the patients diagnosed with heart failure die within the 5 years of the first hospital admission. So patients with heart failure, if they are unwell enough to be admitted to hospital because of for diarrhea and things like that, what we have seen is that the mortality after 5 years actually 50%. Only 50% survive after 5 years, which again most of us don't know. And people are also more scared about a cancer condition. And also the other thing to remember is that 1/3 to half patients will die suddenly, irrespective of the stage of heart failure, because they are more prone to arrhythmias and things like that. So they can even have a sudden death. So that is why this sudden death potential means it actually creates a need for discussion of preference of care from the time of initial diagnosis. So we need to have honest conversation with the patient and the family about the chance of having sudden death, and therefore the preference discussion regarding the preference of care, where would they want to be cared for, all should be made to such patients. Now, this is how we classify the heart failure, and here I've got a classification that is based on both the NYHA classification and the American Heart Association ACC-AHA classification. Now, I think we are all more familiar with the NYHA classification. So NYHA is from class 1 to class 4. So class 1, there is no limitation of physical activities equivalent to a stage B of the AHA classification. Means there is heart disease is present, but there are no symptoms. Now, stage A of AHA is actually which doesn't have an equivalent of NYHA, basically says that there's a heart failure, risk factors are there, but there's no heart disease, so no symptoms. So AHA is classified stage A like that. Then we go on to class 2, which is slight limitation of physical activity. Then 3 becomes marked limitation of physical activity, and class 4 is unable to carry out any physical activity without any discomfort. And that is equivalent to stage 2, where there's a presence of advanced heart disease with continued heart failure symptoms requiring aggressive medical therapy. The reason I am talking about this classification is because all the cardiac medications are started based on the classification. So you can see that these are the common cardiac medications that we normally start for such patients. And the one thing that we need to remember, as palliative care doctors, is that heart failure medications are sometimes we need to probably continue even towards end of life, because they have a role in symptom management. Unless the patients have got very bad side effects of these medications, like BP fall and they're not able to stand up and affects their quality of life, it's better to continue all these medications even towards the end of life. So you can see that diuretics, we start with when the NYHA is class 2, and you continue till class 4. It will decrease the hospital admissions as well as improve the functional status. ACE inhibitors, again, has a role in decreasing hospital admissions and increasing the functional status. Similarly, beta blocker ACE inhibitors and mineralocortical antagonist, which actually prolong survival also. So it's important to keep this in mind when you see patients who are end-stage heart failure. it's always better to make sure they continue all these medications, because sometimes they might not go back to the cardiologist. So maybe it's as palliative care doctors, it's better to make sure we keep them on this medication unless they've got some side effects which prevents them from taking these medications. So I come back to a quiz again. This is already discussed today. So what percentage of patients diagnosed with heart failure die within 5 years of the first hospital admission? Is it A, 30%, B, 40%, C, 50%, or D, 60%? Again, 10 seconds for that.
I think C is the response coming.
Okay, good. So you were listening. Thank you. So it's 50%. They die within 5 years of first hospital admission. Right. Now we move to end-stage kidney disease. Again, end-stage kidney disease also, we know that these people have an extremely poor quality of life. They need frequent hospitalizations, and prognosis is comparable to that of common malignancies. And they also have lots of symptoms, and mainly dyspnea, confusion, pain, anxiety, and depression are very common during the last few days of life. So the role of palliative care in end-stage kidney disease became more prominent after this landmark study was done in the UK. So this was a retrospective observational study published in UK in 2013, which compared the survival and the palliative care involvement of two groups of patients over the age of 70 years. Now, these patients were followed up over a period of time. And once they reached the stage when you have to start the diagnosis, one group of patients just wanted to go in the conservative route, and the other group of patients chose dialysis. So both the groups of patients have got advanced CKD, but one group didn't want to go into dialysis route. They preferred, going in a conservative route, which involved an input from palliative care team also. And along with the kidney people, no dialysis, but all the other treatments will be there. And the other group chose the dialysis route. And they follow these patients over. And what they found is that, and they in the study, they compared the survival, they compared the hospital admissions, and the palliative care access for the patients above the age of 70 with the chronic kidney disease stage 5. So what they found was that for patients who are above the age of 80, who has got a poor performance status or high comorbidity score, the survival advantage of renal replacement therapy over conservative management was lost at all levels of disease severity, meaning the patient who above the age of 80 who went in the conservative route actually survived longer than the patients who went in the dialysis route, if you're more than above age of 80, not for 70, but above the age of 80. So that means that everybody thought, okay, we all expected that the quality of life would be higher if patients went in a conservative route rather than in an aggressive dialysis route, but nobody expected those patients to live longer. But actually, these patients were living longer when they went in the conservative route. So another thing they found was that obviously, as expected, the conservative management pathway had greater access to palliative care services and were less likely to be admitted or die in the hospital. So this again led to lots of joint clinics to be started. And similarly, the renal supportive care in India has also been developed since then. And the renal supportive care work has been starting since 2018. And they also had some didactic through the Project ECHO, just like the ECHO sessions that you're having right now. Lots of palliative care physicians had master classes in renal supportive care, and this is organized by KMC Manipal. And this has also been the results have also been published in the special journal of Indian Journal of Palliative Care. And Manipal has got a dedicated renal supportive care clinic right now. It's led by one of the MDs who's passed from the I think some Tata Memorial. He's leading the renal supportive care service in Manipal. So these are actively going in India also right now. So who would benefit from palliative care and end-stage kidney disease? Now, those who chose and are advised not to embark on dialysis. So, some people might decide not to go on dialysis route. Some people might decide due to financial reasons, they can't go in a dialysis route. These people definitely will need help from palliative care. Now, also those who are failing to thrive on dialysis and who experience worsening quality of life, increasing symptom burden despite dialysis, and those who discontinue dialysis. So we know that dialysis is necessary to keep them alive, as well as to make sure that symptoms are under control. So it's important that if by any chance, so especially with the large burden of end-stage kidney disease in our country, If patients like that are not able to go in the dialysis route, we should be able to offer them palliative care. And what will do you do in a conservative or non-dialytic management end-stage kidney disease? Maintain the fluid balance. You treat the anemia. If needing erythropoietic injections, you treat the anemia with that. Correction of acidosis, hyperkalemia, and blood pressure. Calcium and phosphorus metabolism is very important. Management is important, as well as dietary modification. In addition to that, individualized symptom management. So for sort of pain, breathlessness, pruritus, any symptoms, fatigue, nausea, any symptoms of uremia, any symptoms they have, it's important to manage that. And try and avoid hospital admissions, keep them comfortable at home. And that's the route that you normally follow in the conservative non-dialytic management of end-stage kidney disease. And you need a lot of supportive services for that. Now I'll come to the next session, which is dementia and other neurological condition. Dementia again is very common right now, and advancing dementia. What are the common symptoms? Again, similar to the symptom profile of other patients that we normally see in palliative care, you can have confusion, which is 83%. The most common symptom is confusion. Urinary incontinence about 72%, pain 64%, low mood, constipation, loss of appetite. So again, we as palliative care physicians will be able to help them with that. Now, the other important thing to remember in dementia patients is we need to understand how they progress. So we've got different rating global measures to rate the decline of dementia patients. So you can have something called a clinical dementia rating scale, the functional assessment stage of FAST scale, which is given in the slide, FAST scale, and a global deterioration scale. So this functional assessment scale or the FAST scale has got 1 to 7 levels. It basically tells you about how the function of the patient with a diagnosis of dementia is changing as the months and years go by. So it is basically it's got 7 stages. First is patient has a diagnosis of dementia, but there is no subjective or objective difficulty. That's stage 1. Then they come to stage 2, the complaints of misplacing objects and word finding difficulties will be there. Then, which is like a normal older adult. Stage 3, again, difficulties with normal job performance, which is evident to the co-workers, difficulty of organization, which is considered to be an early dementia. And what we know now is that the average duration of the stage is about 7 years. So people can live like that. Then they go into a stage 4, but it's impairments in the instruments of or the ADLs are impaired, which is considered to be a mild dementia. Average duration is about 2 years. Then they, go on to stage 5, where they need assistance with dressing to match the weather occasion. So, wearing warm clothes for winter and things like that, which is moderate dementia. And what they say is it's about 1.5 years. Then they go on to stage 6 and stage 7, where all the things become difficult. So difficulty in dressing, bathing, toileting without assistance, occasional or more frequent urinary incontinence and fecal incontinence come. Then the speech is lost. So 7 from A to F, this becomes severe dementia. The speech is lost, and they're not able to walk around properly. They can't sit up without assistance, smile, and then finally they can't hold the head up. So that's a severe dementia. Average duration of this stage is about 1 to 1.5 years. But the reason I'm telling you or I'm sort of discussing this in detail is because it's important to identify sort of which stage these patients are. And once they reach sort of like 6 to 7 stage, when you know that they don't have much long to live, so about 1.5 years towards the end of life, it's important to have conversations about advanced care planning. Because what happens to such patients is that every time they become unwell, they get admitted to hospital, they are likely to end up in a ventilator, likely to go to ICU. So we know that they are in a progressive disease and probably reaching an irreversible stage. That's when we need to interfere. So what can we do? What are the palliative care interventions that's possible in dementia? One is symptom control, as I mentioned before. But also we have got role in advanced care planning, avoidance of potentially burdensome treatments, hospice referral, hospice or palliative care, inpatient referral, and a caregiver support. These patients are being looked after by the carers for a long time, and they need a lot of support. They might need respite from looking after these patients. So you could bring the patient in to provide respite to the caregiver or other support that the caregiver gives. On top of that, advanced care planning is very, very important. If you identify that patients are in sort of last few months of life, it's always better to avoid a potentially burdensome treatments. And we need to initiate such conversation to make sure that the advanced care planning happens for such patients. So I'll introduce you to Mr. Krishnan, who is in a local nursing home, and he's 86 years old. He's got dementia. At the baseline, he's bedbound, he's doubly incontinent. He manages a small amount of modified texture diet. The staff at the home comment that Mr. Krishnan hasn't been his usual self. And in the last week, he hasn't managed to eat or drink and has become very quiet. So how should you initially manage a patient? So option A is write an outpatient referral letter to gastroenterology team for consideration of a percutaneous endoscopic gastrostomy or PEG tube to improve the nutrition. Second, send a urine sample for culture, prescribe antibiotics for possible urine infection while awaiting the result. Third option C, clinically assess Mr. Krishnan for any reversible causes of his deterioration, like infection, pain, or constipation. If these are absent, ask the nursing home for details to Mr. Krishnan's relatives to discuss end-of-life care. Or fourth is to refer to physiotherapy to see if they can improve his mobility. So what do you think is the option? What is the right option? Or how do you manage the patient?
I think all the options are C.
Okay, good. So yeah, I think, probably Mr. Krishnan is reaching a stage when, he doesn't have anything reversible going on and he's deteriorating. It's likely end-of-life care. So PEG feeding, feeding is a major issue in all these neurological conditions. If you're going in a route of PEG feeding, we should have thought earlier on, discuss with the patient and family earlier on, but now it's not the right time to do that because I think he's reaching the last days of his life. You don't have to, you can clinically assess him for infection. There's no point in, because if the infection is going to make him unwell, then you can treat it. If clinically there's no signs of infection, why do you have to treat it with an unnecessary antibiotic? So I think the best option would be to assess him clinically, look for any reversible causes, infection, pain, constipation. And if you think that nothing is there, then maybe it's better to call in the family to discuss, end-of-life care. And I don't think there's any role of physiotherapy at this stage. Okay, one more question of dementia. Which among the following is the most common symptom of advanced dementia? Is it option A, confusion, option B, urinary incontinence, C, pain, or D, low mood?
Everyone says A.
Okay. I'll quickly mention some of the symptoms and management or symptom that can happen in the other neurological conditions other than dementia. So you've got ALS or motor neuron disease, amyotrophic lateral sclerosis, Parkinsonian syndromes, multiple sclerosis, ischemic and hemorrhagic stroke. So these patients with these neurological conditions can have some symptom burden specific for them. And you might, as palliative care doctors, might get asked to see such patients to manage symptoms. So there's some specific treatments that is mentioned in the Oxford textbook. So I'll just quickly go through that. So, how do you manage some symptoms? Constipation, again, common for anything else. So ensure sufficient hydration, give osmotic laxatives and stimulant laxatives. Dyspnea, end-stage dyspnea, you can go for opioid route. Then
Sunita ma'am, sorry.
Okay, no worries. Yeah. So anxiety. So you can try sublingual lorazepam, other benzodiazepines as needed. Fatigue. Sometimes SSRI has a role. So citalopram 20 mg day or psychostimulants can be tried. Muscle cramps. These patients, neurological patients, sometimes do have very bad muscle cramps. So quinine sulfate is very good for that. So 200 milligram daily. Pain. You follow the WHO ladder, find the type of pain, and depending on that, if it's neuropathic or nociceptive, treat accordingly. Pseudobulbar effect. Sometimes these patients do, have tendency to actually things like laughing or crying unnecessarily, and that is not able to control when it happens, like an emotional dysregulation. So dextromethorphan, quinidine is sometimes useful for that, and other alternate that is suggested by the Oxford textbook is about SSRI can be tried. Now, pseudo hypersalivation, amitriptyline is very good for hypersalivation, hyoscine, all to dry up the secretions. Psychosis, agitation, quetiapine is something that we try for such patients. Clozapine can be tried. Any sleep disorders, again, clonazepam and melatonin can be tried for that. Respiratory failure, especially for the motor neuron disease patients, because the two things that can happen towards as a disease progresses in ALS or motor neuron diseases, loss of feeding as well as loss of the breathing. So the two things that has to go in the advanced care plan discussion is about peg feeding or feeding issues towards end of life, and the fact that are they going to go into an NIV or non-invasive ventilator. Now, NIV machines are available to be for the patient to use at home. We discharge patients home on NIV machines. We give them for rent for the patients to use at home. So people are living longer. So these are conversations that we need to have with this patient. So if they want to go in the route of NIV, then we have to probably have discussions with them, or tracheostomy route. And a symptomatic treatment for breathlessness, we can go for morphine. Then rigidity, bradykinesia, Parkinson's patients, they'll all already be in such treatment. So, but make sure we continue that, or if they lose their solo, if possible, go in the subcut route if subcut apomorphine is available, or rotigotine patch. I'm not sure whether it's available in India, but these are the other options if the solo is not there. A solo is lost in such patients and Parkinson's patients. Sleeplessness, night sedation, sopicolone, zolpidem, amitriptyline, mirtazapine, quetiapine can be tried. Spasticity, we can refer them for physiotherapy. We can try baclofen, tisanidine, botulinum toxin, if indicated. And secretions can be both thick and thin secretions. With thick secretions, go for muculitis, N-acetylcysteine, and you can use things like nebulized saline, which brings out the secretions, and postural drainage and humidification can be tried. So these are some symptoms that can happen, potentially be seen in the neurological patients, and some sort of symptom measures that can be tried for them. So we meet Mr. Ali. He's a 73-year-old. He's got advanced Parkinson's disease. His wife has brought him to see you because he has been vomiting. Now he has had little appetite over the last couple of weeks and now tends to vomit whenever he tries to take anything by mouth. So which of the following would be an appropriate action to take? Option A, explain that the vomiting is being caused by his medication and start Mr. Ali on an appropriate antiemetic. Second, explain that Mr. Ali is likely to be approaching end of life and needs to be admitted to hospice. Third, assess for any reversible causes vomiting and prescribe prochlorperazine with a view to assessing him again in a few days to check for response. Or fourth is assess for reversible causes for the vomiting and prescribe domperidone with a view to assess him again in a few days to check for a response. So the question is to find out which is the right antiemetic for a Parkinsonism patient. Again, this will be covered in nausea, vomiting, but you can give options now.
These the responses.
Okay, yeah. So yeah, we all know that domperidone and probably ondansetron are the two antiemetics we can safely give in Parkinson's patients. We can't give the conventional ones. And again, this will be covered in detail when you take nausea, vomiting. Okay, we move on to end-stage liver disease. Again, here also there is a role of palliative care. So what is the role? One is to approach the prognosis, to explain to the patient and the family about the prognosis. Symptom management, again, very important, and advanced care planning, as well as end-of-life care. So there are some certain features of worsening of prognosis in liver failure patients. So we know that patient who diagnosed with cirrhosis, if they have compensated cirrhosis, so if they haven't reached a decompensation, you know that the median survival for them is 6 to 12 years. So, but once you reach the compensation starts, so compensation includes ascites, refractive ascites, or encephalopathy, or any liver functions abnormal, any sort of INR is deranged, any sort of compensation features are starting, then the prognosis is cut down to about 2 years average. And what you know, that is patients with ascites, the 2-year mortality for patients who has developed ascites is actually 50%. So half the patients who has developed ascites might die in within 2 years. So 50% is the 2-year mortality. And refractory ascites, so the ascites that is not respond to diuretics and need to be tapped quite frequently. What we know about that is the median survival is only 6 months. Now, the patient has got an encephalopathy, and which is refractory, then the prognosis is 1 year. And the very bad prognosis actually when they develop hepatorenal syndrome. So hepatorenal syndrome, there are 2 types for that. There's type 1 and type 2. Type 1 is a rapidly progressive one, which leads to renal failure. And type 2 does not have a rapid course, and it actually goes very slowly. Type 1, the prognosis is only 4 weeks. So in type 1, what happens is that there's an abrupt deterioration in the renal function in less than 2 weeks' time. there'll be doubling of the creatinine. And there's a 50% reduction in the initial 24-hour creatinine clearance. And that is a very bad prognosis. It's only 4 weeks prognosis. When it's reached hepatorenal type 2, it's a 6 months prognosis. So the worst among them is the hepatorenal syndrome with a very, very short prognosis. Again, this is the same explained in a graph. You can see that median survival for decompensated comes to about 2 years. Encephalopathy comes down to about 1 year. And then refractory ascites about 6 months, and then renal failure about less than a month or 4 weeks. So again, important for them to be referred at the right time. Important for us to have conversation regarding advanced care planning. Important for us to symptom manage them. So for liver patients, pain, breathlessness, ascites, refractory ascites, offering tapping at home if possible, or tapping in your setting if possible. If pruritus, other symptoms also need to be managed. So we'll come to the barriers. What are the barriers? Why doesn't these patients get the palliative care referral like a cancer patient? The main problem is the trajectory. You must be familiar with the disease trajectory of these patients. So the top one is about the cancer patients, where you know that they're on the cancer treatment. They go on for some time with the treatment, and then finally they reach a stage when there is metastasis or recurrence of the cancer, and they have disease progression, and they just go down. And you know that when the things changes, they are reaching end of life. So that is a predictable pattern of cancer patients. But for non-cancer patients and for the dementia and frail patients, you don't have a predictable pattern, because they can go on for some time and they can have a very bad infection, especially COPD can have acute exacerbation. They might end up in a ventilator, end up being an ICU ventilator, but they might come back from that. And so you'll have this conversation with the patient saying that, okay, they reach end of life and then they might recover and come back again. But they won't come back to the baseline. There'll be a slight dip in the curve. Like that, it goes on and finally becomes a baseline. So it's difficult for us to predict actually when these patients become, in stage of end of life. So that is the barriers. That's one of the barriers. The professional barrier is not knowing how long these patients will live. It creates an uncertainty for the doctors, and they don't think it's the right time to refer to palliative care. Then the natural desire to be optimistic, to avoid alarming patients, because you equate palliative care to death, isn't it? So patients and family don't want to hear the word palliative care. Doctors think that death is a failure. So you don't want to think that you're going to fail if you're failing a patient if you refer them to palliative care. Sometimes the doctors don't have the skills of symptom control. You don't have the specialist palliative care service in your hospital, or maybe hospital policy. So all these could be the barriers in professional side. And what about the patient and family barriers? Patient family might think, okay, I don't have cancer, so why do I need to see a palliative care doctor? Failure to recognize as a terminal illness, and caregivers also unprepared, and they can't prepare their mind to decide to transition from the life sustaining to an aggressive comfort care. So patient and families also has this barrier. So how do you help them? How do you prognosticate? So this is a very good tool that can be used. It's called a supportive and palliative care indicator tool, a SPICT tool. It will identify the patients with advanced life-limiting conditions who could benefit from palliative care. Approach the management, not referring to a palliative care service, but having a palliative care approach to their management. So in your management as a primary physician, you have to include the concepts or principles of palliative care for such patients at these points. So this will give you indicators for, there are 2 or more indicators for deteriorating health in all conditions. And there are specific indicators for advanced conditions. So there's an indicator for cancer, for dementia, frailty, neurological disease, for heart and vascular disease, respiratory disease, kidney disease, and liver disease. So there's some specific features in that. So what we say is that 2 or more general indicators of deteriorating health and any clinical indicator of 1 or more advanced conditions means that they should have intake of palliative care or support of palliative care principles at that point in the disease trajectory. So for example, in heart vascular disease, in NYHA class 3 or class 4 heart failure, or extensive untreatable coronary artery disease with breathlessness, chest pain or fatigue at rest, severe inoperable peripheral vascular disease, gangrene or pregangrenous extremities. In kidney disease, which you have seen before, stage 4 or stage 5 chronic kidney disease, kidney failure that is complicating the other life-limiting conditions or treatments, stopping dialysis and avoid advanced diabetes unresponsive to treatment, deteriorating health, including kidney failure. Liver disease, like we have seen, advanced cirrhosis with one or more complications like diuretic resistant ascites or ascites requiring recurrent drainage, hepatic encephalopathy, hepatorenal syndrome, bacterial peritonitis, and recurrent variceal bleeds. So what we normally recommend is that access to palliative care should be based on the need rather than the diagnosis. So just like as I mentioned earlier on initially, so it's all the suffering. Is the suffering serious enough for them to get the support or palliative care approach to their management? So it shouldn't be based on the diagnosis. And another strong recommendation is a surprise question that we tell the clinician to ask that. So suppose you see a patient in front of you in the OPD, and you ask yourself this question: will I be surprised if the patient died in the next 12 months? And if that answer to the question is no, that means you are not surprised. You will not be surprised if the patient dies within the next 1 year. That means that patient needs a palliative care input. So that is a surprise question. It is found to be highly sensitive. So if in your practice you see patients who you think is not going to live for more than 1 year, then maybe that's the right time to initiate discussions of putting the principles of palliative care principles, including advanced care planning and symptom management. So to conclude, this palliative care is needed for patients with serious health suffering, which includes both cancer and non-cancer. And we still have to do further research into the needs assessment tool for specific conditions, as well as the evidence of benefits of palliative care involvement. Right, thank you very much for listening. I think we can take some questions.
Thank you, Dr. Sunita, for covering all the many aspects of palliative care in non-cancer illness. We can take up a few questions. You can either unmute or type in the chat. How many of you see actually non-cancer patients in your setting, in palliative care? I know some people are already working in a palliative care setting. How many of you do you or your institute take care of patients with non-cancer illnesses? Anyone? Dr. Shetty, in your setting, do you see non-cancer? Or just, I understand you already do some work.
Hello.
Yeah, yes, ma'am, please.
Can you repeat the question?
No, I was asking, in your setting, do you see non-cancer patients, palliative care patients, or?
Actually, what is happening in our area, whenever we get a call, like we have some kiosks in some of the medical colleges, and whenever we get a call, usually we go and visit them. And definitely we have two patients. Like one is maybe, I think she's 90 years old and she's totally bedridden. With all, she's on Ryle's tube feeding and symptomatic treatment. That she's lying down for last 6 months, more than 6 months. And otherwise, no, most of the cases are cancerous patients because we are getting cases through this kiosk only.
Thank you. I think Dr. Vanita is mentioning that yours is a neuropsychiatry institute, but is there any palliative care element there? Because neuropsychiatry is one area where we do have many patients.
Ma'am, we have recently started our neuropalliative care OPD, ma'am. And we have also a proposal for starting an inpatient ward currently with 6 beds and then plan to increase it.
May I ask you which institute you are from?
Ma'am, I'm at EBHAS, ma'am, Delhi.
Okay.
Institute of Human Behavior and Allied Sciences.
Okay. So you're planning to start a palliative care facility in your institute?
We have the OPD, ma'am. We are planning to start the ward.
Okay, that's great. And would you like to share like what kind of patients do you get referrals in your OPD? Like at what stage at least? Is it like terminally ill and then they refer to your services, or you get referrals much earlier in their illness?
No, ma'am. Currently we are getting, it is like very late only, ma'am. Like what we are trying to tell, like, involve the other institute so that we get early referrals, ma'am. Now it is like it's only at a terminal stage that we are getting. So there is nothing much that we are able to do currently. But we are trying to spread the word among the other institutes so that they can send them in early. And once our ward is also started, then we will be able to provide a better facility for them.
Yeah, thank you so much for sharing. Just to understand, like, which all setting you all work and do you see non-cancer palliative. Thank you for sharing, Dr. Vanita.
Thank you.
Dr. Ariba, yes, you do get patients in the late stages, maybe because, or you don't get much referrals in your institute because other departments are not aware of. So, do you work in a cancer center or in a medical institution?
No, ma'am, I'm actually working in a tertiary care. It's like which is actually guarded by the center. It's KIMS SORA in Kashmir. So we have different departments, but they are not much aware about the importance of this. Like it's like they only say like only the patients who have end stage who are having cancer or at the end stage of their life, they are being referred there. But recently some of the patients with rheumatoid arthritis, adhesive capsulitis, and other bone problems, they came to us. Obviously, they were not at the end stage of their life. They actually got relieved and they were like, oh, we have this kind of a department there. And we were like, yeah, we are actually working on it now. We are trying to like spread the news that like you'll get pain relief even if you don't have the serious conditions. It's not only the cancer that we only deal with. We have other like diseases also, conditions also.
Thank you, Dr. Ariba, for sharing. Dr. Sunita, you have a lot of experience in Kerala working in a setting where you do see a lot of non-cancer illnesses also. So, how would you go about like giving awareness among other medical professionals? Like these are all people from different parts of India. Like Kerala, we know that it's much better. People know about it, but how should they go about telling that we are not just working for terminal cancer, but also for other life-limiting illnesses?
So I think the difference with Kerala and the other states is that because Kerala, the community palliative care is very strong here. So the base of palliative care in Kerala is home palliative care community. And this is led by the volunteer network. So they are the ones who are getting the patients to get the palliative care team. So what happens is that, they get a lot of patients who are chronically bedridden, paraplegia, stroke, those set of patients will come because ultimately they know that bedridden patient is palliative care. So that way we get a lot of non-cancer that way. But if you think of all these patients that I've, all the conditions that I've mentioned in the presentation, we don't get them involved because nobody knows that, like COPD or heart failure. Still, nobody knows that they need palliative care input. So the other place that I work was in a busy private hospital. So that is the other place where we can integrate palliative care with non-cancer conditions. If it's like a tertiary hospital which has got cancer and non-cancer. So say for example, respiratory. So I mentioned about chronic breathlessness syndrome. This is we did a study in Amrita Hospital among the doctors working there. So it was a focus group discussion, and I invited specialists from pulmonology and cardiology and oncology to come and have a discussion about the prevalence of chronic breathlessness syndrome. Is it important? No. So like that, and then they realized that actually you could do things for such patients. So what we tried to do was, have a chat with the pulmonologists, see whether we can start some joint clinics there. Tell them about the importance of non-pharmacology management and see whether we can involve palliative care early on for such patients. So that is one specialty. There was cardiologists also there, but cardiologists were still not very keen to have palliative care involved because they were thinking in the mode of devices and treating the patient. They're not thinking in the other way that there is a stage when you probably will have to stop all the treatment. Then other setting is ICU setting. So again, palliative care and intensive care is now coming up specialty in India. So again, I think from Manipal and other side is happening. We had masterclass on that. So how do you talk to anesthetists and others who are in charge of ICU? You talk to them about the need for, suppose that no further active treatment is needed or indicated for such patients, then why do you keep them in ICU unnecessarily? We need to move them out of ICU, make sure they're with the family, make sure the symptoms are taken care of. So all those conversations, and that we have to empower the ICU physicians to do that, because otherwise they have to call us for all the time. So ICU physicians will also think in that terms. Why do you have to keep a patient unnecessarily in the? And it's difficult in private hospital. It's not easy, because in private hospital it's all about getting money goals. So you have to make sure they understand the need for not keeping such patients in the ICU. Another is liver. So it's all about but in the community, once the patients if it's a government setting and once the patients are known to palliative care in the community, then sometimes for liver patients like ascites, we have trained in our district, we have trained the nurses to do ascitic tapping at home, and all the nurses in our unit are trained to do that. We take at least 5 liters at home. So that will avoid the patient to come to hospital. So it avoids post-hospital admission, so they can be managed at home. So things like that, we should be able to, sort of empower our staff to do that and try and increase services and integrating.
Thank you. Thank you so much. I think, it's important to talk to other specialists about the scope of palliative care, because many places it's still a cancer care. So while you are meeting people on the corridor over a coffee, just talk about it like, there is a publication where they integrated palliative care for respiratory illnesses or cardiac, and some people might be interested, and then they will want to know more. Like currently, we run a course for pulmonologists, and we were actually slightly anxious, like, will they be even interested to hear the term palliative care? But we had a lot of registrations, and the questions they ask is very similar, like, oh, we are stuck when there is nothing more, no more cure to be offered. How can we keep them comfortable? So the problems are there, but maybe they don't know like what can be done. Once the reversible is not possible, then what else? So it's about spreading the word among your colleagues. If you are in a medical institution, teaching institution, you can talk to the interns, get them 1 or 2 days rotation in your department. So during those 2 days, give sensitization for them. So because they are anyway going to be the future doctors. So all these kind of, wherever you get 2 minutes, just talk about the scope of it, then use. And as Dr. Ariba was mentioning, when a few patients get cured and when they are not terminal, then the others and as well as the patient will feel that, okay, there is something like this happening. I can always go there, and this is what they do. So the words from them also will be very, very helpful. Yes, Dr. Shweta.
Ma'am, like you said, actually, there are doctors who are trying to build up their own specific small scale palliative care teams, wherein, and especially, I've also noticed that many parents of, children with, I'm largely talking about neurodevelopmental conditions here. We don't really see any other systemic conditions, but a lot of these neurodevelopmental groups, so parents have formed groups, and generally they approach doctors and rehabilitation specialists, and then they work together as a small unit. So here, what they try to do is, apart from symptom management with the medical professionals handle, there are certain, skill building workshops that are conducted by the physiotherapists, occupational therapists, and doctors, maybe, neurophysicians. They then train that little group of volunteers and the families, and then take care of the symptom management. So this is something that I've specifically noticed in, again, cerebral palsy cases, in autism cases. So I think even families are now becoming more aware. So these are not terminal stages, though. These are more towards the, young adulthood, that stage. Yet there is lack of awareness about what to do when, even symptoms like epilepsy come in between. They don't know that, but it is slowly building amongst that group. So they're becoming more aware of the symptoms and the need for networking. So I guess it will, with community participation, it can become even more proper, streamlined.
Yeah, very good point. I think that even in Kerala, most of the referrals for palliative care comes from the community than from the other specialists. In oncology, yes, they do refer, but other illnesses, usually the community knows about it. the scope of it, and then they come, or the volunteers find out and then refer. But compared to that, direct referrals from the other specialities will be lesser in our setting. Thank you. Thank you for sharing that. If there are no other questions right now, we can move on to the presentation and then we'll take up other questions. Dr. Balawan?
Yes, madam.
Please go ahead.
Good evening, everyone. I'm Dr. Balawan. I'm a physician working in Government Taluk Hospital, Fort Trivandrum. My patient is a 55-year-old gentleman. His diagnosis, chronic kidney disease stage 5 on maintenance hemodialysis thrice weekly. Diabetic nephropathy, type 2 diabetes mellitus, systemic hypertension, coronary artery disease. Next slide, please. Presenting complaints: breathlessness, abdominal discomfort, and itching. Next slide. History of illness. The patient is a known case of chronic kidney disease stage 5. He has been on maintenance hemodialysis thrice weekly. Now he is presenting with increased breathlessness and difficulty in lying down. He also complains of abdominal discomfort and nausea. He also complains of fatigue and itching all over the body. He was diagnosed to be suffering from chronic kidney disease in 2018 and has been on maintenance hemodialysis since then. Initially, he was undergoing hemodialysis twice weekly, but following repeated episodes of breathlessness, his hemodialysis frequency was increased to thrice weekly 4 months back. Initially, hemodialysis was done using right IGV catheter. Later, left radiocephalic AV fistula was created, and now hemodialysis is done through this access. 2 years back, he was admitted with chest pain and was diagnosed to be suffering from coronary artery disease. He was a chronic alcoholic and smoker. He has stopped it 10 years back. On examination, he was febrile, BP was 190 by 100, JP was raised, there was a desaturation, SpO2 was 93%, just had bilateral cramps, so there was evidence of fluid overload. Pedal edema was present and scratch marks was present due to pruritus. Next slide, please. Treatment and significant investigations. As you can see, there was anemia. Hemoglobin was 7.6, serum creatinine was 8.8, and urea was 120. Then here hyperkalemia with a potassium level of 6.6. ECG had evidence of LV with strain due to hypertension. Papai was negative. He was treated with diuretics, antihypertensives like amlodipine, clonidine, torsemide, and oxygen inhalation. He was given hemodialysis, following which his breathlessness decreased. He was on hydroxyzine 25 mg BD for itching and antiplatelets and atorvastatin for coronary artery disease. He was on erythropoietin for 4,000 units sub-Q twice weekly and iron sucrose infusion once weekly for anemia. Next slide, please. Psychosocial aspects. He belongs to a lower middle class family. He has 7 siblings, 3 sisters and 3 brothers, and all of them are manual laborers, so he does not have any financial backing from his siblings. He used to work as an electrician until he was diagnosed to be having CKD, and he has not been able to go for work since he was started on maintenance hemodialysis. And his wife is also not working as a bystander was required for maintenance hemodialysis. His wife is also not going for work, and she is coming with him. He has 2 daughters. Elder daughter is married, and she has a daughter, and she is residing in her husband's house. Younger daughter is unmarried, and she's working as a lab technician. At present, the family's expenses are met by the younger daughter. He also had to take some loans for his elder daughter's marriage, and he has been trying to repay it. He knows about his illness and its consequences, but he finds it very difficult to follow his dietary and fluid restriction orders. He consumes a lot of fluid in between dialysis, and usually the interdialysis weight gain is usually around 5 kg. At present, he is undergoing hemodialysis treatment under the CASP scheme. So the hemodialysis part is covered by the CASP scheme. Then he's Hindu by religion and a believer in God. Next slide, please. Medications. He's on antihypertensives, amlodipine 5 mg BD, clonidine 0.1 mg thrice daily, and tocilizumab. He is taking antiplatelets and statins for coronary artery disease. And for anemia chronic kidney disease, he's on injection erythropoietin and iron sucrose infusion. And for his itching due to uremia, he's taking hydroxyzine 25 mg BD. And he's also on insulin for diabetes. Then salt and fluid restriction was also advised to avoid fruits, and also he's undergoing maintenance hemodialysis thrice weekly on Monday, Thursday, and Saturday. Next slide, please. Main concerns. In spite of undergoing thrice weekly dialysis, he is still having intermittent episodes of breathlessness, for which he's getting admitted and taking dialysis. And he was given strict fluid and fluid restriction and salt restriction orders, but he finds it very difficult to follow the dietary and fluid restriction orders. And he hardly now he says that he hardly passes any urine now. So he was asked to take around 500 ml of fluid per day by his nephrologist, and he finds it very hard to limit the fluid intake to such a low to 2 to 3 glasses of water per day. And he also complains of persistent itching despite dialysis due to uremia. And disease, he also knows that the disease cannot be cured in spite of treatment. More of his concern is about the financial concerns due to his inability to work, and he cannot contribute to the his family income. And he also has psychological concerns about the marriage of his younger daughter. Summary: a 55-year-old diabetic and hypertensive gentleman who is a non-case of chronic kidney disease stage 5 under maintenance hemodialysis thrice weekly, and coronary artery disease, now presenting with evidence of fluid overload and uremia. And discussion points to be discussed in the class. A patient, from the patient's point of view, coping with the incurable nature of the disease despite treatment. And second, coping with the dietary and fluid restriction orders, which he finds very difficult to follow. He also has concerns about the future of his family, his daughter's marriage, and her job. Then financial concerns, as he's finding it difficult to work as an electrician due to his regular hemodialysis. Then he also has concern about inability to work. Then from the point of view of his family, concerns regarding the incurable nature of the disease, also this financial expenses related to treatment. Right now, his hemodialysis is covered by the CASP scheme, but still they have to get the medicines, and for that they are spending it from their pocket. Then financial concerns regarding the daughter's marriage, and emotional and psychological aspects of dealing with the death of their family head during one of the exacerbations. Thank you.
Thank you, Dr. Balwan, for the detailed presentation of your patient. And I'm glad that you've thought about, at least you have explored all these concerns, what are the concerns the patient had, and what are the concerns the family is having about the illness. So that's, I really want to thank you that you have explored all these things. That is something beyond the usual medical management, right? We don't ask these questions like, what are your concerns? What are you finding it difficult to cope? So all these points will come out only if you explore the non-medical part of it. So that's, I would like to ask others, based on today's session, do you think or when should we integrate palliative care in this kind of patient? Like, and what are the things that we can do? Suppose Dr. Balwan is referring his patient to you all, one of you, for palliative care services. Do you think this is the time for referral? When should he refer, and what all can be offered by us? I'd like to hear from other participants. What do they think? I guess at least some of you will take the referral first of all. Yes, Dr. Aditi.
Ma'am, I think in this patients like CKD, I think when the initiation of dialysis is only there, the palliative care involvement should be there, because we do not see a kind of complete cure in once a dialysis is started. And obviously like a diet management becomes very important, and that is what one of the difficulties this patient is finding it. So, it is a constant process and a constant involvement. We cannot be giving just that randomized or printout of the diet. It has to be day in and day out involvement for a diet management. So that is, these two things, according to me, I look forward for, and rest looking forward for more suggestions and guidance from the team.
Thank you, Aditi. Thank you, Dr. Aditi. Anyone else? Any other inputs? Yeah. So one of the concern is finance, and he should be guided about different schemes. Yes, because he is unable to go for work anymore, and now the daughter is supporting. But what about the prognosis? Did you get a chance to discuss the prognosis with the patient, Dr. Balwan? Like, what do they understand is going to happen? Are they looking for cure?
No, he knows that his condition cannot be cured, and he also knows that it will eventually get worse. But right now, maybe he can be redirected. Right now, he is healthy enough to maybe he cannot work as an electrician, but maybe he can be reoriented to some other work. But he's not open to it at this point of time. And I have been trying to discuss with him about the dietary and food restrictions as well, but he just will not obey, and he usually takes one full watermelon before the dialysis, and saying it is hot, and he could not avoid fruits in between the dialysis. So it's very difficult to make him understand the problem of taking more food than water in between the dialysis. But maybe he can with the help of a community or some psychologist or something, maybe he can be reoriented to some other job which he can do, because he's not bedridden at present. Is in between the dialysis is okay. There only in between only 1 or 2 episodes of worsening breathlessness. Otherwise, he's okay.
Yeah. Thank you. And just one more question. Sorry for asking so many questions. Where do you see him as a patient in terms of the surprise question that Dr. Sunita was mentioning?
Actually, I don't expect him to die in 1 year, because he's healthy. He's responding to the dialysis treatment at present. So I don't think he'll die in 1 year. I hope.
Thank you for that. Dr. Chaitanya, would you like to unmute and talk? Like you have mentioned about the discussion on goals of dialysis and talking with the family regarding the prognosis. And I'm sure that you are dealing these kind of situations in your setting. Would you like to speak a bit about it?
Yeah, so based on the reports and the clinical assessment that was presented, he seems to be in fluid overload, hyperkalemic, and anemic. All three are indications for urgent dialysis. So my assessment would be that either he's not compliant to dialysis or he's not getting sufficient dialysis. And I would want to know more reasons. And presuming that he's getting sufficient dialysis and he's not responding, I would want to set goals of dialysis with the family together.
Thank you, Dr. Chaitanya. Dr. Srikanth is mentioning about the assessment of mobility, activity, endurance, emphasis on the activity pacing, energy conservation techniques will help in symptom management. Wonderful, yes. So these are the small things that we might, yes, Dr. Srikanth, please unmute and talk.
Any thoughts, ma'am? Just a question from my side.
Okay.
So role of morphine here when dyspnea sets in.
Yes.
I mean, so in terms of the assessment of dyspnea, the severity as well as the BOG perceived exertion. mean, in such cases, how would you approach morphine, and when would you start it in this case?
Yeah, yeah. I'm reserving that question for Dr. Sunita. Yes, morphine might be helpful in this kind of patients, but the dosing might be different. Dr. Sunita, would you like to take that question right now?
Yeah, it's a bit tricky because morphine is actually contraindicated in this GFR, EGFR, because EGFR less than 10, morphine will accumulate in renal failure. So if it's pain, we don't give morphine ideally if we have other options available. So for the pain management, the opioids that is safe in renal failure are buprenorphine, fentanyl, and oxycodone, which is not available in India. Buprenorphine, fentanyl are available for pain management, and obviously methadone. But these are not tried for breathlessness. The only thing that is tried for breathlessness is morphine. So that's a very tricky question, and especially in this patient who is on active dialysis treatment, then I would, because otherwise we have to go with a very, very low dose of morphine. So what happens in, we give morphine for renal failure patients, but we just have to give once daily dose. Even for short-acting morphine, just one dose will maybe enough for the whole day. So normally it's 4 hours, but this accumulate. So that is how we titrate it for pain management in patients where we can't get any other option, like fentanyl. So it's tricky because for breathlessness. So, if you really have to give it, I would, opt for very small dose. But obviously studies have been done in with morphine and CKD breathlessness. The studies of morphine has been done only for COPD patients. Even heart failure also, with studies, they haven't had any evidence. But we give for COPD and cancer breathlessness. But for CKD, we haven't done that. So that's a tricky situation.
Thank you.
Thank you, Dr. Sunita. Even I agree to that. We had a few patients with end-stage cardiac failure with breathlessness and end-stage renal failure on, not end-stage renal failure, on dialysis and breathless. And it's important to have the communication with this treating doctor, because you're prescribing morphine, and it should not be a problem with the treating physician. So we try to have a discussion with the primary physician, and seen market difference in some of them in terms of breathlessness, but you have to be really careful about the dosing, as Dr. Sunita was mentioning. Very small dose and not 4th-hourly dose. Usually once or twice daily would work really, really well. But I have seen a few who got marked improvement in breathlessness, and they could sleep, they could do their, at least go to toilet on their own without being very breathless. So, yeah. And Dr. Sunita, about the other part of it, like how do you counsel, like he knows that the prognosis, he is going to be having dialysis, but then he can't restrict the fluid and the foods intake or any dietary restrictions.
So that is actually going to be tricky, because I understand that Dr. Balawan mentioned that he probably is going to live more than 1 year. But the tricky situation is he's got hyperkalemia, as the other doctor mentioned. He's not keeping to dietary thing, and there's a chance that he could have a sudden death also, so maybe the hyperkalemia and things like that. So I think it's important. First, we need to try and find out why he's not able to follow the dietary restriction. Is it because he just don't want to do it, or we should try and find out what exactly is happening with him. Maybe lots of discussions are needed regarding that, because that could be the reason why he's going to fluid overload even between dialysis, isn't it? So I think it's not very easy to tackle this. And the other thing I like what Doctor mentioned about him having, we need to train him to do something else, like some other activity, rehabilitation purpose. See whether he can get some other job that he's able to manage. And once he's got something to do, then maybe he could be depressed as well. With all this happening, he's quite young, isn't he? So he feels that he doesn't have much longer. Then that's the reason he probably be thinking, why should I bother with all the dietary things? I'm tied to dialysis anyway. So why am I doing all these restrictions? So see whether we can rehabilitate in some other way, get in some other job, and see whether, in that way, will he be more engaged and more, if he has got things to look forward to, maybe he'll be more sort of engaged in following the dietary advice. I don't know, I'm just thinking aloud here.
Thank you. Dr. Chaitanya, please go ahead.
Yeah, just I mean, I'm curious to find out what is the 12-month mortality rates for end-stage renal disease in India. I'll try and find out and share it in the group if possible.
Yeah, please.
That would be
Will be useful. Yeah, will be useful.
And Dr. Rashmi?
Yeah, hi ma'am. I'd like to just add a point to what Sunita ma'am have just said from one of my personal experience, because even my grandmother, she was polycystic kidney disease, and even she was undergoing the same kind of mentality when she was taking treatment. She was having this thinking that she is old anyways, and whatever it is, how much treatment you are going to give, I'm not going to live ahead. So I don't think this is going to help. So that mentality, I think it comes up for such kind of people. And from this case presentation, it is very clear that he is thinking that he is being a burden over the younger kid, and he's also worried about her future. So I think acts very much importantly on this when we can do, but to make them understand that you have to take treatment, or explaining them, it plays a very important role there. So I would like to add that to what Sunita ma'am have told. That's it. Thank you.
Thank you, Dr. Rashmi, for sharing that. I also have a similar experience with my own aunt who had renal failure and was undergoing hemodialysis thrice in a week. And she knew that it is incurable. She has to undergo dialysis whole through her life. And there were a lot of restrictions in terms of diet. And she is a person who likes to eat. I mean, go out, eat, and come back. She was quite upset and depressed just because of the dietary restrictions, and she wanted to eat and drink properly. And we all kept counseling her. I was not into palliative care then. We kept insisting on keeping the dietary restrictions, and then she died within a few weeks. She didn't live long, but she was not on. I mean, all these were happening, she was not really on the end stage kidney disease category. But then she passed away within a few weeks of short months. But then still think I could have given what she asked at least in the last few weeks. That's still there within me. Because she was just asking for a few drops of water, nothing else during the last few days, and she wanted to go out and have ice cream with all of us. So yeah, that was still something which I really think should I have given something at least. So that's something which we need to think also. Yes, Dr. Balwan.
Just want to say, just as Sunita Madam said, I actually talked to the patient, but he was not willing to listen to the dietary advice, and I talked to the family as well, and they were telling that he was following starting dialysis and following this advice for few years. Now he is very angry and he is not open to suggestions, even to his family members. And maybe he's not following this dietary advice because of psychological problems. Just
Yeah, maybe he might
discussing.
have fed up with not eating and drinking for many, many months, right? It's kind of,
Yes.
yeah, we all feel that if you can't, and you are not really looking forward to, okay, after a few weeks, I'll be able to drink or eat. That's not there.
Yeah.
He knows that this is going to be his lifetime thing. So I think it's very important to give an opportunity, as Dr. Biju was mentioning, give an opportunity to vent his anger towards life, anger towards his own existence. What is the meaning if you can't? That's what my aunt keep telling. See, I know I'm going to die. I'm going to be on dialysis. What is the point in restricting all this from me? At least let me eat what I want. And she really looked forward for the day of dialysis so that at that time they let them eat something. So she prepares the previous days itself. Like next time when I'm going for dialysis, what am I going to eat? So that becomes so intense then because there is nothing to look forward to. Yeah, so I think it's important to give a venting opportunity for him to let out his anger because that's quite natural, right? If we can't eat for 1 week, some fasting we are taking, then we know that next week we are going to eat or drink. Thank you so much for sharing. Dr. Shetty, please.
Yeah, Dr. Sridevi, just since our today's discussion is mainly on the non-cancerous disease. That widened palliative care. I just want to mention something because I usually go and visit this Mother Teresa's organization. You might have heard about that. In Calcutta we have. And what is like, they are treating more terminally ill patients, and even ordinary, like, general cases also they do. But most of the cases, even if it is terminally ill patient, that is managed by general physicians only. So here, what is the role of palliative? Because they are also managing them for so many years. They may not be interested in doing other, but they are also somehow managing the cases. So what is, as a palliative care unit, what do you expect from us?
Dr. Sunita?
Sorry, I didn't catch that. It's about Mother Teresa Center where?
In Kolkata.
Sorry,
in Kolkata, we have so many organizations. This Mother Teresa's organization is running so many institutions, including palliative. They say it as palliative because terminally ill patients are there. And I do go there, and main thing, like, they have general physicians, and they are managing these patients. And what is my question when we discuss about this palliative care idea? So how do this our service would make a change?
Okay, so the general physicians are there. So do you know how they are managing the patient? So I think the idea is to find out how effectively the care is happening. Okay, so where does the palliative care make a difference? So say for example, symptom management. What's the symptom burden of these patients? Can somebody sort of assess that? And is there a need to the patients that has not been addressed by general physicians? It doesn't mean that you have to go and do it. You can even train the general physicians on the palliative care principles. So if is this patients destitute, or is it they have family with them?
No, destitute. So you can expect only destitute.
Yeah. So I think
but
that
they are like, if at all any surgical cases, they call surgeon. The orthopedics case, they call orthopedics people. And for psychiatry, we have one psychiatrist also. So generally, I go and give some, like, what you can say, physical presence and some sort of care, because I don't go very often.
Are you a palliative care physician? Are you? What is your normal job?
I'm attached to Eastern India Palliative Care Unit of Kolkata.
Okay,
so I'm a general physician for last 30 years.
So they would be mentioning, right, when they call you. Why do they call you?
No, it's for my voluntary service only. I am attached to them because since I'm in Kolkata. Now the question arises when we are talking about palliative care. What's the difference? Because this is already that concept is there. Some senior people will be there and they are devoting their time for the poor people. And as a palliative, how we can make changes? That's my question.
Okay, that depends on the situation, the condition of the patient, isn't it? So how do you do that? You don't have to be a palliative care doctor to provide that. The main thing is the physician is looking after the patient is able to provide the palliative care principles. So principles of so say for example, symptom management. Is the pain being properly assessed? Is the patient getting all the pain management as needed? If they don't have the training for that, then you should be able to provide that for them. Breathlessness management. Are you able to provide a specialist palliative care help for the patient for breathless management? For nausea, vomiting. So all those things, symptom management, are the physicians able to provide that support? If not, are you able to provide? The second one is advanced care planning. So you say that people come and surgeons come there. Suppose they've got some issues where will they be transferred to hospital? Do they have to be admitted to the intensive care unit? Are you able to provide some advice about that regarding the prognosis of the patient? So that again, you should know about the diagnosis first and then decide at what stage of illness they are. If they're just in the center because they're destitute, that means they don't have anywhere else to go, but they're not technically a palliative care, then you don't have to have much input. But you will have patients at different stages of illness, isn't it? Different trajectories of illness. So depending on that, you could provide your specialist service with whatever skills that you have learned from the training that you received.
Okay, Dr. Sunita.
Thank you, Dr. Sunita. Sorry, I echo Dr. Sunita's opinion, because they don't need to be palliative care doctors. Like many doctors, even if they are not trained in palliative care, they have that palliative care approach. And if their patients are out of distress, they are calm and they are happy, they don't have any distress, then that's fine. We don't know whether there is a need. So I think checking whether there is a need is one thing which we can do. Because many a times if you notice, I've seen many specialist doctors, they have not trained in palliative care, but the way they talk to patients, the way they understand and take care of people who are dying. It's like amazing. So they don't have to be a palliative care specialist, but any palliative care approach, or if their patients are symptom free, distress free, then that's well and good for everyone. Thank you for that question. And Dr. Ravi has a question. Like in advanced cancer, we say about the like whatever they like, let them eat, because anyway they are in the advanced stage of cancer. Can we have the same approach when they are in like non-malignant cases also? Dr. Sunita?
Yeah, so again, that is tricky because for dialysis purpose, if you're doing dialysis on one side, trying to keep patient alive, then we probably will have to restrict his diet, isn't it? Because we're not doing him any favor by saying that he can eat anything. That is the problem. Advanced cancer it's different. It's similar to saying you can smoke. If you've got cancer, it's okay, you can smoke, but you can't say that to a COPD patient, because we know that the smoking is going to make his COPD worse, and he's going to become more symptomatic, isn't it? So I think that's the problem. But again, as Dr. Sridevi said, if she still feels the fact that she was not able to provide whatever that her aunt wanted, in spite of the fact that her aunt was not in that last stage also, isn't it? So I think it's very tricky, that situation. We can only advise a patient with the things that we know. We know that the dietary habit or fruits are not in the best interest if they have a hyperkalemia, and if we're not able to save them, and what's the point in subjecting them to this thrice weekly dialysis? Know how to answer to that question.
I think there is no right or wrong answer,
Yeah.
but it is about having a discussion with the patient. And I understand Dr. Balwan's patient is going through dietary restrictions for many years, and it's quite natural to be angry because he's still in that same stage. But it's important to have and if the patient is getting more symptoms, more distress out of this, so then it's up to him to decide whether he, like giving a smoke to a COPD patient, if he's going to cough and be breathless for more, then they should think about and have a discussion. Like, is it okay to have that cough? Is it worth having that? Is something that we need to discuss.
Yeah.
Dr.
Also,
Chaitanya, sorry.
The comment with Dr. Shweta about the role of clinical psychologists, I think it's very good comment in the chat box. So even Dr. Balwan's patient, I think we need to assess his psychosocial and maybe do a scale. You do a depression, a HAT scale on him, hospital anxiety depression scale, and see how much he scores on that. Because if you remember the symptom profile that I shared, a CKD patient, both depression and anxiety are very common in such patients. So maybe an antidepressant or anti-anxiety might help him with the symptoms, because even for cancer patient, we know that they've got a cancer diagnosis and that is causing depression. But actually, depression can make you non-compliant with chemotherapy. So we are justified in starting antidepressants for them if they're not like dying imminently. Antidepressants take some time to start working, but maybe if you do a HAT score or see whether it's clinically depressed or anxious and start some medications which can actually cover both anxiety and depression, he might be better compliant to whatever advice you're giving. So that could be one thing that you could try to do. And if you have got a clinical psychologist, and well and good, see whether they can spend more sessions with the patient and help them. They might open up to them rather than to us, and see whether that can also help.
Thank you. Dr. Chaitanya, you had a question or comment?
No.
Okay.
Just that most of the points were covered. Okay.
Thank you, Dr. Chaitanya. Thank you, everyone, for the wonderful interaction.
Sridevi, I just had
Yes,
one more thing.
Yes,
so
please.
for pruritus, uremia can cause pruritus. You can actually give, so it's mainly because accumulation of phosphate. So I think I presume he's on phosphate binding thing already. But there's some evidence to give ondansetron for uremic itch, and even gabapentin, but very low dose gabapentin. So ondansetron is helpful both the nausea and the itch, and low dose gabapentin. These have got some, benefit for uremic itch. So because this patient had that, I thought I'll add that also.
Thank you so much, Dr. Sunita, and thank you everyone for the interaction. Thank you, Dr. Balwan, for bringing in a good story for us to discuss about and learn from each other. Thank you everyone for another wonderful session. Shri.
Thank you, Dr. Sunita, for joining us in spite of your busy schedule and finding out time for this cohort of doctors. And thank you everyone for joining in. And I believe that everyone here could get at least a glimpse of the vast spectrum of the non-cancer illnesses and the scope of palliative care in those. So with that note, this is Shripriya along with Dr. Sunita Daniel and Dr. Sridevi Warrior signing off from the Tips Echo Hub. Please,
Shripriya, sorry, I've just put a link. It's a
Yeah,
Google
yeah.
form for my feedback.
Yeah.
If it's okay with you, I collect personal feedback. So if you could just spend 5 minutes to fill that form, it will be useful for me.
Yeah.
sure, ma'am, we will get it there.
Just
Thank
send it to
you.
us also. We'll circulate in the WhatsApp group that we have.
I will
Just,
do. I'll reply to the email then. Okay.
Thank
Thank you
you.
very much. Thank you.
So please do send in your feedback as well. And with that note, this is Sripriya signing off. We will see you in the next session with another interesting topic and another eminent faculty. Till then, everyone stay safe, be happy. Bye-bye.
Thank you. Bye.